Our first speaker is going to be Dr. Daubert. He's going to teach us about CRT non-responders.
Good morning. Thank you very much. Well, it's a pleasure to be here. Thank you very much for the invitation, DJ and your team. And you're right. You've really accomplished a lot, bringing this great crowd together here in Kansas City. And I didn't come here for the barbecue, or I didn't come here for the songs about what's in Kansas City, but just because this is a terrific meeting. But I must admit I'm a little worried because you've reminded us to try to stay on time, and then you're handing out an announcement about tasers, so I will really do my best. So, couple words about CRT. It's quite effective. I'll be focusing on non-responders, so I don't want you to take the wrong message away. It really is a dramatic therapy. This shows results from the CARE-HF study. On top is heart failure hospitalizations or death. On the bottom is mortality alone. And remember, this is CRT pacing only, so this is not a mortality benefit of the defibrillator. This is patients with an EF under 35, a broad QRS, New York Heart Class 3-4. If they had QRS of 120 to 150, they had to have dysynchrony as well. And this showed dramatic reduction in both those endpoints I mentioned and has led to a Class 1 indication. More recent studies, including MATED CRT, RAFT, and REVERSE, have shown that this therapy works for New York Heart Class 2, more mildly symptomatic patients, but with a similar substrate, and even reduces mortality in that population. However, you'll hear this bandied about, is that only 2/3 of patients respond to CRT. And is that a problem? Well, a fair number of these devices are implanted, and they're rather costly, so you could come up with an astronomical figure of money lost if this is true, and it is true to a certain extent. One problem we'll get into a little bit more is what is a non-responder? There are a number of ways of looking at it. We could look at echocardiographic data, we could look at heart failure hospitalizations, we could look at mortality, we could look at symptoms, New York Heart Class being one, and we'll get different answers. So if we look at LV remodeling by echo, we might see that about half of patients respond to a dramatic or definite degree. But if we look at ask the patient, are you feeling better, or see what New York Heart Class they're in, we'll get a higher value for responders. So there probably is a placebo effect to CRT, like most therapies. I'm going to skip over that one. So this is a review of this topic, and the bottom line here is 26 publications defined CRT response using 17 different criteria. The agreement between the methods was poor 75% of the time and strong only 4% of the time. So this highlights data from the Prospect study and other studies demonstrating that our ways of analyzing response, of assessing echoes for dysynchrony, their agreement with clinical data, with symptoms, is poor. And these show the different response criteria that have been used in a number of different studies, and the print is so small you can't read it because there are so many. Well, I think we do know a little bit about response. I think there are some things we can hang our hat on a bit. This is data from MATED CRT and looks at the percent change in LV end diastolic volume at 1 year after implant of a CRT, and this is a randomized study of ICD versus CRT. The ICD patients are in the open circles, CRT in the filled squares. And you can see greater remodeling is towards the left on the x-axis, minus 35% change in LV end diastolic volume, for instance. And on the y-axis is a primary event rate after 1 year. Primary event rate was heart failure, hospitalization, or death. So you can see more remodeling towards the left has much less event rates, which is good. So you want to be in the lower left corner here and not in the upper right corner where you have more events and less remodeling. The ICD population is clustered in the upper right, the CRT in the lower left, but there is a range of response, if you will, for both groups. So getting back to what we know about response, if we look at echocardiography as done here, I think it has a pretty good correlation to important hard endpoints, mortality or mainly heart failure hospitalization in this study. So echo remodeling is probably something we can hang our hat on. Now, I put this in just to say that we shouldn't go too far and only look at the patients who remodel a lot and not implant others with CRT. Because when we looked at MADE CRT, the outcome for ischemic cardiomyopathy versus non-ischemic cardiomyopathy, we saw that both groups had a good response in terms of the primary endpoint, preventing heart failure hospitalizations or mortality. Yet the non-ischemics remodeled to a much greater degree. So remodeling is important, but we need to take into account the harder endpoints as well. So what about non-response? If we're seeing a patient in clinic and he or she is somehow defined as a non-responder, what does it due to? Well, you can see could be due to a lot of things. Suboptimal AV timing, arrhythmias, suboptimal lead location, lack of bi-V pacing, which is often due to arrhythmias or due to suboptimal AV timing. The patient may not have had a wide QRS to begin with, may not be compliant. There's a whole host of things. Let's talk about the AV interval first. Is it important? Well, I think you'll recognize that it is. There are studies going back many years, excellent physiology studies in dogs and people and computers, and they show that the AV interval has an optimal level, and the mitral valve should be moving toward closure at the onset of ventricular systole. That seems to define what an optimal AV interval is. If it's too short, LV filling time is reduced due to early termination of atrial ejection due to ventricular systole. If it's too long, the mitral valve closes early, limiting diastolic filling. So cardiac output's maximized in CRT when LV contraction occurs at the completion of LA contraction. So this is too short, this is too long, and this is just right. The E and the A waves are aligned properly. Whoops. So the AV interval is important. It's one of the causes for non-response, if you believe the data from the Cleveland Clinic, which look very strong. Can it help? Can optimizing the AV interval help? Here's an anecdote, just to cut to the chase. This patient got a CRT and really wasn't any better at all. Came to the optimization clinic, had an echo, reprogramming and all, and her general cardiologist saw her back and said she was a new woman. Her echo was different, she felt much better. So certainly anecdotally, it seems to help. But how do we do it? Again, we're struck with how many methodologies there are for optimizing the AV interval, and there are too many to read, as you can see. They look at mitral filling, they look at aortic ejection, mitral valve flow, and a number of methods, desynchrony, speckle tracking, tissue Doppler, et cetera. A number of methods and not good agreement between them. So here's a very important study that looked at all comers getting a CRT, the smart AV delay, and randomized them to 3 approaches. You heard about the echo-guided approach where we optimize mitral valve filling. That's in the middle there. There's an algorithm that looks into account takes into account the PR interval, the QRS duration, called the smart delay. And then there was just set it at 120 milliseconds for everyone in that group. They were randomized to these 3 groups, And unfortunately, there was no difference in the primary endpoint of change in left ventricular volume. Remember, that's an endpoint that we think is important. No difference, no improvement with all that time measuring the echo and adjusting the AV interval 10 milliseconds, taking another look. It didn't seem to matter if we do it to every patient. Oops, wrong button. Another study, the QuickOpt algorithm from St. Jude. This data was presented by Bill Abraham at HRS 2010. Randomized patients to having frequent optimizations. This algorithm could be done every time they're in clinic. And it was in this study versus control, just one optimization with echo or whatever the operator or the investigator deemed was best. And again, there was no benefit of QuickOpt optimization in this study. Another thing that's been looked at is V to V delay. You have a bi-V pacemaker, you could pace the RV early, you could pace the LV early, you could pace them simultaneously. This is the Decrease HF study. Looked at a number of things, focused on VO2 and echo remodeling. And by the primary endpoint, there was no difference whether you paced simultaneously, sequentially, or paced LV only. Bi-V seemed to be slightly better, if anything, in this study. So optimizing the VV interval in everyone may not be a panacea either. Well, getting back to that data from Cleveland, where they took in patients who hadn't responded to CRT, they tried to optimize the AV delay, and they did seem to see that patients who they changed the AV delay, they could see something was wrong when they got to clinic, they changed it based on their data, and they thought they were doing something good. These people tended to not come back for heart failure hospitalizations. They seemed to do better, whereas if they didn't find something that could be adjusted, they did worse. So in some cases, it looks like AV optimization could help. And it may be that it's a small subset of patients. We're looking at this at Duke in a pilot study, looking at patients with a distinct right atrial to left atrial delay, and these patients may benefit from optimization of the AV interval to a much greater degree than all comers coming to CRT. Well, the next important thing is optimizing the amount of bi-V pacing. And you can see that you really need to pace almost every beat. If you're not pacing 99% of the time, the outcome in terms of heart failure hospitalizations is pretty dismal. Atrial arrhythmias are a big cause of this and result in a lot of fusion and pseudofusion. Excuse me. And even if you think people are rate controlled, they're often not. Even if the device says they're bi-V pacing, they're often getting fusion beats and not really getting effective pacing from this 12-lead Holter study. PVCs are another problem. Our chairman for the symposium presented this nice data last year showing that patients with frequent PVCs who don't have a response to CRT could be treated with ablation and improve in proportion to the amount of PVCs that they had and the amount of bi-V pacing they weren't getting. Scar is another problem. If the ventricle is scarred, it may not be possible to get a good response with CRT, and particularly if the scar is in the lateral wall. This is another cause for non-response. There's not a lot we can do for that other than better select candidates if this is really true, and you'll hear more about that in a couple talks from now. Well, lead location is something we can do about. And for years we thought the best place was the lateral wall, the posterolateral wall doesn't matter otherwise. This data from MATE at CRT found an interesting result that if the lead was placed in the apex, the patients did poorly. If it was anterior, anterolateral, posterior, it didn't seem to matter as much as long as the lead wasn't in the apex. And you can see we can judge the lead location from the RAO view on the left or the LAO view on the right and determine whether it's basal or apical from that RAO view and whether it's anterior or posterior from the LAO view. And it may be that if we target the lead to the site of latest activation mechanically, we may do better according to this preliminary data from the starter trial. So basing the lead location, the implant, on where the late area is activation may be beneficial. Well, again, we've talked a little bit about non-responders, and this is some sobering data also from Cleveland that showed that 40 patients admitted with advanced heart failure who had had a CRT for at least 3 months all had gotten worse in terms of their echo despite having CRT. Yet when they turned off the CRT in clinic, 88% of them got even worse. Their blood pressure dropped, their cardiac output went down. So they may be a, quote, non-responder. They may not have improved with CRT, but they might have done even worse had they not had CRT. So this non-responder thing is really multifactorial. Some people would have been worse without CRT. Some people shouldn't have gotten CRT. Some people can have an improvement in their AV interval. Some people may need a lead revision to get the lead in the right spot. And some may have arrhythmias that could be corrected with ablation of PVCs or AF or the AV junction. So a protocol for this may be helpful, looking at the lead location, interrogating the device, optimizing the interval, and if all else fails, they may have to move on to LVAD or other advanced therapies. And we don't think that this should be done in every patient, but rather should be done on patients who don't seem to respond, and ideally measuring that by echo at about 6 months after implant, although the symptoms are important to take into account as well. And there's some other interesting things in terms of lead location that are coming along. We may need to place 2 LV leads to treat some of these non-responders, and there's studies ongoing that are looking at this. Or we may need to place the lead endocardially, transseptal approach to the LV. Some data that there may be better response in general, and certainly in some patients when pacing endocardially rather than epicardially via the CS. So in conclusion, I'd like to tell you that the response to CRT is multifactorial, that you may want to strongly consider getting an echo 6 months after implant to assess LV reverse remodeling. Consider lead revision if the lead is apical, or maybe if it's anteroseptal and they haven't responded. AV optimization is part of a protocol for CRT non-response, not routinely for everyone. Think about PVCs and AF. See whether the patient is better with the CRT on or off, and evaluate whether they have electrical and mechanical dyssynchrony. So I'll stop there and appreciate your attention.